This is a 64-year-old lady. She has history of a CVA, dizziness, and all of this happened before October of this year. I'm sorry, October of '08, and that's when all of this transpired. So she went to see the surgeon. She had carotid endarterectomy. I think you can see on the history slide she's hypertensive, hyperlipidemic, diabetic, etc. So she has risk factors. And she came to see me immediately about several months after that, which was approximately 2 months ago. And she was having recurrent symptoms, the same ones she had before her surgery. Her surgeon actually sent her here because he did an ultrasound, which showed, as you can see on our films we took about 2 months ago, if someone can pull those up, you can see a lesion in the common carotid, which looks like where the cross clamp was placed. And then you can also see a lesion up above that in the internal. We draw a line perpendicular to the inferior arch, to the bottom side of that arch, draw a perpendicular line across the top of that arch, and anything that's above that line is a very favorable arch for us, such that we can go from the descending aorta with a fairly straight shot. So I think you can see in all of these vessels that we have a fairly straight shot to the right and left internal carotid artery.
Okay.
All right.
So what equipment are you planning to approach that with?
Ty wants to show you this Gore device, and then we're going to go over to Ramey to do a case while we get prepared with it.
So this is an antegrade perfusion case, right?
Right. Right. So this is a proximal protection or flow reversal system, and this is the Gore system. So I think you can see there's a balloon on the end of the sheath here, at the sort of the working end. Back here we have a port to inflate the balloon. We have a working port to insert the balloon stents wire, and then we have another arm here, which is the one that we're going to connect to this filter to perform the flow reversal. So we'll create an AV fistula from the carotid.
So the benefit, Ty, is that the arterial blood flows through that filter back into a vein, right? So the blood isn't lost.
That's correct. So we can either have active or passive aspiration when we do that, or reversal. And we also have a balloon here that we're going to use to occlude the external carotid artery while we're doing this. So there'll be a balloon inflated in the external carotid and a balloon inflated in the common carotid, and that is going to allow us to have a flow reversal.
Right.
And Chris,
Ty or Steve, do you know from the cerebral angiogram, is this an isolated hemisphere or not?
We can show you those images of that, and this is not an isolated hemisphere. And
so do we know about tolerability of this balloon occlusion device based upon isolated hemisphere? Can we predict who will and who won't tolerate these devices?
We probably can't. Intuitively you would think patients that have an isolated hemisphere wouldn't tolerate it, but they may not tolerate the initial balloon inflations, but by deflating the balloons and giving them a few minutes to recover, we've done a case. Remember, you and I did a case where the patient didn't tolerate the initial balloon inflation, but after about 3 or 4 minutes of waiting, they did tolerate the subsequent inflation.
So I think that's one of the things that we've learned since the original days of distal occlusion with the PercuSurge device, was that patients can actually be trained.
Right.
And I think the other thing we've learned is that you can't predict, as much as you try to predict what's going to happen, you never know until you inflate the balloon.
Okay.
So if I could show you one more thing with the cameraman here, Chris, if you look at the groin, what we placed is a long...
Can you take pictures like that, Kenny?
Get ready next door.
Is a long 10-French sheath. You can see that
we... gorgeous or what?
We pre-closed this, Chris. And if you look in the left groin, you can see that we have a venous sheath. So that's what we'll use to create our fistula. Go.
So you see the sheath tracking around into the common carotid. This sheath has a real long dilator on it. So,
what sheath is it, Ty?
This is the for the neuroprotection system. So, can we see the next picture, please?
So it's a 10 French sheath?
It's 9 French, 9.5.
And we have the 10 French long sheath in the groin.
So Steve got this up into the common, and then he just basically held in the wire and the introducer telescope the sheath into the common carotid, sort of at the level where we're going to be working.
Okay.
And we wanted to position this where we'd be able to inflate the balloon in the common and actually see that, and then see the area where we'll be working in the common and the internal carotid. So We've done some road mapping. What Steve's doing now is getting ready to.
I've placed the external carotid balloon in the EC port right here.
And so since we have a stenosis in the common carotid, before he actually positions this, I'm going to inflate the common balloon.
But do you think we ought to take a new road map since it's moved a little since we took that one before we start?
Yeah, hang on. I think
So,
you're okay.
huh?
Yeah, I think you should. That's
Is
pretty
that blurry to you, Chris?
Blurry.
Okay. So we're going
right,
to put it
so-
on road map. And before we do that, Ty's going to hook up with contrast. We'll take a road map, and then we should be ready to go.
I should open that a little bit, Steve. Let it
Open this.
open this one.
Okay.
So what's the panel's experience
You ready?
Open
with
open this.
flow reversal systems?
Flush to
Positive,
Flush.
negative?
That's
Okay.
Jury still out?
Ready for road
Positive.
map? Ready, Chip? Yeah.
You know, what's interesting to me is this is a 9 French device, 9.5 French. The MoMA
Stop.
device is a 9 French device.
Okay.
And you would think it'd be more difficult to navigate in
that
there.
road
It's
map
really
better?
not. Both of these devices are well made, and they both
You
are
wanna go ahead?
nice
I
and
wanna go ahead
floppy,
and
so you
open
can
this.
get them around a difficult arch.
Uh-huh. Are there people that you preferentially select for flow reversal, or does everybody get it who can get it?
Go ahead.
Well, I think interestingly, there are centers in Europe that are almost exclusively using flow reversal, or at least proximal occlusion
Yeah, I think so.
with the MoMA
It's a
device,
small one.
and we're getting great results. Hitachi's results are, unmatched, and
So you can see him steering.
so I think it's just a matter of we always
wire
worry about
into the
shutting off the
external
cerebral
carotid.
circulation, but for the amount of
And
time
actually
we
with
shut
this
it
system,
off
because the
with
wire is
proximal
not
occlusion,
attached to
it's
the sheath like it is
insignificant.
with the MoMA device.
I mean, think about
it's very
what's
easy
the
to
average
get
length
in
of time
position.
that the carotid is occluded during an endarterectomy in the NASIT trial?
Yeah, I think you did.
32
Just turn it a
minutes.
little bit more.
So this is nothing. And if somebody does get in trouble, as Ty mentioned, if you occlude the carotid and they show symptoms and you just deflate the balloon, wait a few minutes, let the pressure come up a little bit, and reinflate, they'll usually sail right through. So-
Yeah, there's ischemic preconditioning, I think, that
Band is
happens.
back in
Yeah,
the-
and I'm really impressed that in patients who are recently symptomatic, or if they have
I'll pull it out.
a really echolucent plaque, this may be the thing that gets us through and gets our results up to the same as endarterectomy.
No?
So Kenny, what percentage of the cases you do are flow reversal?
Close it.
Incredibly few, but that's in part because I've only done one Gore device during the trial, and it's only recently been approved. So I don't have a lot of experience with that device, but I used the MoMA a few times when it was in investigational trial, and it's now sort of moving its way through. I find that device a lot easier to use. So I anticipate when it's approved, I'm actually going to use it probably, I'm guessing 20% of the time.
Mark Krieger, do you ever see yourself looking at an ultrasound at a plaque and saying to somebody, you ought to use flow reversal for this because it looks like an embolic or embryogenic plaque?
No, I don't actually recommend to the interventionist which type of disc protection device to use, but I do increase their awareness that it's an unstable looking plaque that is friable or likely to embolize, and then let them decide.
What about you, Mike? Do you think you can
Okay.
tell?
We're all struggling with this. I was hoping that this grayscale median score would make its way into a clinical trial, but that probably won't get funded unless one of these stimulus plan
Hey, look, let's see.
submissions gets accepted. Then it will be. So I think that would be helpful.
Wiggle it a little bit.
Okay, so now if you'll move the patient there, you should be able to see the balloon on the sheath.
Yeah, so the balloon's inflated around the cuff of the sheath.
And now Ty's going up on the external. And we're protecting all this time.
Yeah, I'm not getting this. I think you. bit
So
the
now you're
femoral
going to
tube.
create this AV shunt through the
Is it going
Yeah,
up?
no, I think you
femoral
bit the
vein, right?
hypotube when it's correct. We have it on active or passive aspiration now, but I think the hypotube.
No, I see the balloon up.
Stop.
The balloon,
When you say passive, Ty, you just mean that the blood
it's
pressure is
not.
driving the
Hang on.
flow?
Stop. No.
So I think it's obvious that you don't
We're
see
As opposed to
the
actively
external balloon, so the
aspirating
external
with it.
balloon
are you
is
sure the
inflated.
balloon's not inflated right now with a bubble
So you
on
need
it?
to make sure that
See
the
that?
balloon is actually inflated, before.
Yeah, it's
before you
inflated.
proceed.
See the
Yeah, I see it now.
Can you see the external balloon,
I
Chris?
think so.
Yeah, the thing at the bottom there.
And you see it looks like it may have a little air in the balloon.
No, he's talking about the external, I think.
So what Ty's going to do now is he can determine if we have proper protection by injecting here.
So the biggest problem with all of the occlusive devices is missing the lesion. So
this
how
is
do
one
you
of the things that
avoid
you see
losing
with the,
track of the
with
lesion?
with the flow
Thank you.
reversal
It's
device,
being
the
played
question
with.
earlier this morning about
So it ties inflating
can you
the external
inject
just a
when the
little more.
balloons are inflated? So you actually inject.
So I think
don't
you can
wanna
see the sheep
overcome
took a little bit of work, but now we have,
the flow
we have
reversal.
reversal.
So you
Do
can
you
do
wanna record
a
that?
slow injection
Yeah, I see
and
that,
actually see
Todd.
that the
You
dye
saw
is
it, okay.
going
So are you gonna
back into
pre-dilate,
the,
Steve?
into the
Yeah,
sheath.
we're
We're going to
advancing.
pre-dilate,
with
so
the
he's going to
wire.
advance the wire. I want the angioplasty balloon.
Yeah.
So what size balloon?
Can I have a torquing device?
It's on there.
4x2.
So the data is crystal
So
clear that,
you want to show
that
me the
any
lesion so I
ischemic
can see
event
where to steer?
is a harbinger of stroke, and the highest risk is in the first 2 weeks. So with either procedure, our goal should be able to get the carotid fixed as fast as possible. With stenting, the reason that the results are not as good is because if you've ever seen a plaque at surgery,
Right.
a week
You got
after